Hello, welcome to the Center for Connected Health Policy's Telehealth and Medicaid Policy Webinar Series, the Winter Edition. Today's topic will be on provider engagement and education during the public health emergency. My name is May Kwong. I'm the Executive Director at CCHP, and I'd like to welcome you to the second edition of our webinar series for this winter. A few housekeeping things before we begin. Please know that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational and educational purposes. If you need a formal legal opinion, please consult with legal counsel. Also know that CCHP has no relevant financial interest, arrangement, or affiliation with any organization related to commercial products or services that may be discussed in this program. Please note that today's webinar is being recorded and the slides presented here will be available on CCHP's website about 48 hours after the webinar. We also ask that people refrain from making political statements or advertising commercial products or services during this webinar. We ask that if you have a question for our panelists, please use the Q&A function. The chat function is merely for technical difficulties you may be having with Zoom. A little bit of background about CCHP. We were established as a California telehealth organization in 2009 underneath funding from the California Healthcare Foundation and California Endowment. We're a program underneath the Public Health Institute, but an opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available in 2012. We applied for that and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on specific projects related to telehealth and connected health. We are one of 14 telehealth resource centers who are underneath the same grant program. There are 12 regional resource centers that cover specific states and 2 national centers. CCHP is the one on policy and there is one on technology based in Alaska. We also work together underneath the umbrella of the National Consortium of Telehealth Resource Centers. I encourage you to reach out to your regional telehealth resource center if you have questions regarding telehealth. The Center for Connected Health Policy team is made up of 7 incredible individuals. I'd like to especially thank Samuel Taylor for spearheading this webinar series for you today. The reason CCHP created this series is that we have found that there was, especially during the pandemic, a lot of things that were going on in Medicaid around telehealth policy that perhaps not as many people were aware of, and that other Medicaid programs may find useful to learn from their peers. We started this last week with a series webinar that focused in on the response to COVID-19. This week is on provider education and engagement. Next week will be on patient education engagement. And then on February 5th, we'll be looking at what's down the road next for telehealth policy and Medicaid programs. We ask that you follow the discussion on Twitter and use the hashtag Medicaid Telehealth CCHP. We also like to thank HRSA for providing the funding to make this webinar series possible. Right now, I will turn it over to Samuel Taylor, who will be leading us through today's discussion. Samuel?
Thanks, May. My name is Samuel Taylor, as May just said, and it's my honor to introduce 3 Medicaid administrators from 3 very unique and different states. Today, we're going to be hearing from 3 experts who are leading and driving innovative changes to their telehealth programs in their respective states during the public health emergency. First, we're going to hear from Dwayne Young with the Nevada Division of Healthcare Financing and Policy, also known as Nevada Medicaid. Keep in mind, we will be doing individual Q&A with each of the presenters and then coming back and doing a panel-wide Q&A at the end of all 3 presentations. After Dwayne's presentation, we'll be doing an individual Q&A with Dwayne. And then after Dwayne, we'll be hearing from Dr. Shannon Dowler with the North Carolina Medicaid Department of Health and Human Services. Last but not least, we'll be hearing from Nicole Small, who is a health systems administrator in the Policy Management and Development Division in Ohio Medicaid. Next slide. It's my honor to start by introducing you to Dwayne Young. Dwayne is currently the Deputy Administrator over Medical Programs and Community-Based Services for the Nevada Division of Healthcare Financing and Policy, which is commonly known as Nevada Medicaid. He has nearly 20 years of experience in the field of behavioral and public health and has worked in the public sector in Indiana and Nevada in both state court administration and with state departments of health and human services. Dwayne received his bachelor's in science and science degree in family studies from Miami University of Ohio and a master's in management from Indiana Wesleyan University. Dwayne is also currently working on his PhD in organizational leadership at Indiana Wesleyan University as well. Without further ado, I'm pleased to introduce to you Dwayne Young.
Good afternoon, and I want to thank you all for having me today so that we can talk about policy here within Nevada. We can go to the next slide. I've included just some basic slides so you understand policy from Nevada's perspective on telehealth. Telehealth is really the use of communication systems to substitute for in-person encounters for professional consultations, office visits, office psychiatry visits, and a limited number of other behavioral health services. What we're going to talk about today is how we came to the progression of that expansion of services. Next slide. So who can practice telehealth? Well, in Nevada, it's anyone who maintains best practice standards, obviously, and is clinically appropriate, meaning that they're practicing within the scope of their practice as a healthcare provider defined by their licensing board or credentialing body. Telehealth was created in Nevada through a Nevada Assembly Bill 292 in the 2015 legislative session, allowing it to be reimbursed for Medicaid and all other payers. This was important to highlight. This was a bipartisan effort amongst our state, as many of you may or may not be aware of. Nevada is made up of 17 counties, with only 2 of those being urban counties, the rest being rural and frontier counties. And so we were absolutely reliant as a state on telehealth. Next slide. So all of the policy requirements for telehealth are actually the same as they are for in-person services. So if there's a prior authorization that's required for an in-person service, that same prior authorization will be required for a telehealth appointment. They must be clinically appropriate. And one of the important things that Nevada did to establish from the start to encourage the use of telehealth was to have parity in payment for in-person health services. And we did this because, again, as I mentioned, those rural and frontier counties, one of the things in my previous role when I was deputy administrator over clinical services, I traveled with the chief psychiatrist for the state, and we looked at the people within our rural and frontier communities who were experiencing crisis episodes, and they had been in in emergency rooms for several days. And so one of the things that we found was that through the use of telehealth assessments of psychiatrists and clinical social workers in urban areas, that could help the critical access hospitals then manage the crisis of these recipients, refer them to proper care in our hospitals in urban areas if needed, or be able to have a plan of safe discharge with community follow-up. And so we partnered with the Nevada Association of Rural Hospital Partners, who then had a grant for telehealth equipment to really push the impotence of telehealth use to solve some of the backlog we had seen in really treating behavioral health crisis management. Also, we found, we have always stated that these services must be delivered via HIPAA-compliant audiovisual telecommunication centers. I'll talk more about the Office of Civil Rights relaxation of enforcement on this a little bit later in my presentation. We also do not require a telepresenter as a condition of reimbursement. Next slide, please. The non-covered services for this, of course, include telephone calls with the caveat for the exception of crisis services. Crisis services have always been allowed by telephone, but all other services were excluded to this due to that Office of Civil Rights directive. Images transmitted by fax, text messages, or any electronic mail. Next slide. We also had the following services that weren't specifically outlined within our policy, but were included in our billing guide, and we managed with system edits. And so these services were basic skills training and psychosocial rehab, which are both rehabilitative mental health services with a focus on bringing a person back to the level that they were prior to their behavioral health crisis, personal care services, home health services, and of course, private duty nursing services. Next slide. And I know many of you are familiar with billing telehealth, so I'll just go over the nuances that are within Nevada. We charge for our originating site. It could be the patient's home, school, or other clinic. And then we also include that the provider of the originating site must be located within Nevada or a Nevada catchment area. Again, because of our rural and frontier population, we heavily rely on our surrounding states providers to also service Nevada. And so many of those providers are enrolled in Nevada Medicaid, even though they are within another state, and they do help and assist and treat Nevada Medicaid patients. The distance site, however, can be anywhere, and we often enroll providers who are distance site from all over the country who are willing to provide care to our recipients. Next slide, please. The unique nuances for the originating site is they do bill a HCPCS code as along with the place of service O2. It cannot be billed if the recipient is at the home. The distance site, they just simply build the place of service code O2. One of the challenges in the pandemic is with the relaxation of those standards and the allowance of telephonic use within telehealth. We would like to add another modifier at some point so that we can track those calls that are being delivered through traditional telehealth means and those that are being delivered through telephone. Next slide, please. So I want to talk to you a little bit about what we did and how we educated our patients and providers. As I mentioned earlier, because of the critical need within Nevada and because of our lack of healthcare service providers within the state, many of our states had been defined by HRSA as healthcare deserts, meaning a dearth of providers, even including some of our urban areas like Clark County, which you know is Las Vegas, or Washoe County, which is Reno. And so we have been focusing and pushing on telehealth really as a means to provide some healthcare equity in these underserved areas. The policy, as I mentioned before, though, began to rapidly change. We convened a small strike force within the division across many specialties within programs led by our medical services team, which reports to me, who is responsible for the telehealth policy, to within the first days of the coronavirus, really look at what was happening, read all the documentations, and look how that we could have flexibility. We were grateful for taking these actions because Nevada went into a very stringent stay-home order in which elective surgery procedures were put on pause, as well as in-person dining and many other things. And so we knew that people would have apprehension about taking care, and if didn't absolutely need to be seen, could be seen via telehealth. And so one of the first things was the federal government relaxed the Office of Civil Rights Standards for non-HIPAA compliant platforms, meaning telephonic, Skype, FaceTime, Zoom, and many other flexibilities. And so that was one of the first flexibilities that we relaxed. We didn't do a change within our policy, but what we did is we authorized memos that aligned and superseded our policy. And I'll show you those in a moment. We also temporarily lifted the restrictions that we had placed within our policy on using the use of telehealth and group therapy. And so one of the things that we did early on into the pandemic is that we had a lot of providers reaching out to us because they were concerned about continuity of care. They were also concerned about being able to provide services for patients under our stay-at-home order. And so we didn't want to just take, the providers, but we also wanted to get some recipient feedback as well as getting feedback from the various licensing boards and credentialing bodies. We also worked very closely with our Children's Mental Health Group out of the Division of Child and Family Services and the State Mental Health Authority, as well as the State Public Health Authority out of the Division of Public and Behavioral Health. And so they helped guide us because we believe the job of bureaucrats is really to lead and guide and craft policy that is influenced by the science and the study of those within the field. And so it was very important to have these partnerships as well as get the feedback of providers and recipients. And so we did all of these memos within the first 2 months of the pandemic, with most of them coming within the first 10 days. The next was really challenging. And so having those partnerships with those bodies that I just mentioned was really important in understanding how physical therapy, occupational therapy, and speech therapy could be utilized through telehealth. And so what the caveat there in the rule was that they had to maintain visual sight on the recipient. Additionally, we had allowing for home health agencies and hospice agencies to conduct the initial certification and reassessment, in addition, waiving the requirement for the nurse to be on site every 2 weeks and providing those services via telehealth. As you all are aware, COVID-19 spread to these vulnerable populations. And so being able to have a solution very quickly within that first week of the stay-at-home order to make sure that these visits still occurred, but ensuring the health and safety of the recipients and the staff was very vital to us. Two other flexibilities that are very important because they were a challenge to us, and it was something that we worked with the certification licensing boards, as well as the state mental health authority, as well as our sister agencies, to really come to something, because we wanted to maintain the integrity and the level of efficacy within services, but we also wanted to allow, and particularly when services impact children, scientific research has put out there that any evidence-based intervention is better than none at all. And so we came to the conclusion that we really needed to allow for applied behavioral analysis, or ABA, services to treat autism, for the assessment and the parent training to be conducted via telehealth, as well as additional one-to-one adaptive behavioral treatment. And that was really a big milestone to be able to, as well as psychosocial rehabilitation, which is one of those rehabilitative mental health services that I mentioned earlier. We allowed these for those under 18. Specifically, we had in Nevada a population of children within specialized foster care who have a higher regimen of behavioral health services. And we knew that the allowance and crafting guidance for telehealth and how telehealth could be administered with the integrity and standard of care for these services was very important to that population, not to see any regression or loss of skills in that population. Next slide. And so this is an example of we created a COVID-19 webpage that was adjacent to our Nevada Medicaid page. Each had a link to the memo. We also did provider blast out to our boards and commissions and through various state agencies to get the information out. One of the things that I do want to highlight is just the dedication of my staff. Nevada Medicaid is a smaller program compared to many other states. And so I had one policy specialist at that time who was over telehealth. And so what we did is we worked with our district offices and our care coordinators, the social workers and nurses. We had everyone send questions titled telehealth because many providers, and while our rural and frontier providers certainly were equipped for telehealth and understood telehealth, many of our urban providers did not and were not prepared to begin offering services to telehealth. And so they needed a lot of technical assistance. So our district offices filtered that, and our dedicated policy staff person, along with others who volunteered, answered every single email, every single call, provided technical assistance to every single person. And then myself and my chief convened high-level meetings with groups to inform them of the work that we had done and to walk them through the basics of telehealth, and presentations very similar to this. And so this was a combination of a very hard and long effort of very dedicated staff who worked very long hours in the beginning of the pandemic to ensure that these flexibilities were out, and that people and our staff and that stakeholders felt comfortable enough, as well as recipients, as well as with a focus on underserved communities who typically had to rely on in-person services that would no longer be getting those in-person services. And so the last memo occurred in May, and we have not produced any others, but the feedback that we've gotten on those flexibilities to be able to continue, we've seen certainly an uptick in telehealth from where we were before the pandemic as it continues to grow, particularly for those in need of behavioral health services and primary care, as our hospitals are still at capacity due to the surge in cases. And so next slide. We also have here some resources: our Medicaid Services Manual, our chapter, which has not been updated since 2017. And I was really grateful for that because of the nature of our state, that we had really pushed this policy to a place in 2017 that was flexible and allowed for many of these flexibilities that these memos could be plugged into them. And so we also have our telehealth resource guide and some of the resources that we used and we provided out to providers that needed additional resources beyond the training that we could provide them. One thing was where are we going next? And so I'm sure, like most other states, our state, we're about to enter our legislative session. We've worked with our Patient Protection Commission, which was established by our governor in the 2019 session. They are bringing forth a bill to make sure that all other payers are focused in the language of Medicaid, and so that they are also providing pay parity for services, and that they are allowing the maximum flexibility for telehealth through other providers. And so normally when a bill is put out, we as Medicaid kind of scramble to see what it will cost and what it will take for us to get there. So it's very nice for once to have bills put out there and languaging put out that is encouraging other plans to follow the lead that Medicaid took, in 2015 and 2017, and certainly at the beginning of this pandemic. And so looking forward, we know that there will be other bills that will look, I think like most states, we're waiting to see what HHS will do with the flexibilities in the Office of Civil Rights, if they'll allow to continue telephonic, or if they will allow some allowances for HIPAA compliant platforms beyond the declaration of public health emergency. And so we are waiting for that, and we will kind of wait for that information before we produce any permanent changes to our chapter. But that is where we are at, like many other states, allowing that flexibility until the end of the public health declaration. And so I also have here my contact information as well, and just some acronyms afterwards. And Medicaid, we love our acronyms, just for those that didn't to relate or didn't catch them as I was speaking to them. But I will pause here for questions that you all may have. Samuel, if you're speaking, we can't hear you.
So sorry about that. Well, I was. Thank you for that. Thanks for that great presentation, Dwayne. I want to invite everybody participating in this webinar to ask questions for Dwayne and Nevada Medicaid now related to their provider outreach and provider education initiatives in the state of Nevada. Please remember to use the Q&A function. And the first question I'm going to start with is a question that we actually received through our registration submissions. The first question is, can you provide details on whether you did any outreach or support for dental providers in Nevada Medicaid?
Yeah, that's an excellent question. So within Nevada Medicaid, we actually have a capitated provider for dental. And that group actually have been doing some outreach prior to the pandemic. They have been working through they worked through a pilot program of teledentistry, in which recipients could go to a location, get a camera inside their mouth, and get the services of the dentist to advise them. And this was really a deterrent from our emergency rooms, because we found a lot of people were showing up in emergency rooms with dental emergencies and kind of clogging the flow. And so that work that had been done just really translated really well to the pandemic, to really continuing pushing that out to deter people from coming to the emergency rooms, because of course it was needed for the COVID-19 surge. And so that work really just parlayed really well into what we were already doing, and allowance of those flexibilities.
Excellent. Our next question is related to your telephonic coverage. You noted that Nevada Medicaid's existing policy does not cover audio only. We have an attendee who's interested if Nevada Medicaid is considering expanding permanently to include telephonic only coverage after the public health emergency.
That is something that has certainly been brought up. That has actually been brought forward in bill by, we have regional behavioral health boards. So one of our regional behavioral health boards have brought that up. As we have understood in our consultation with CMS, is that is really a lack of enforcement by the Office of Civil Rights. And so CMS has granted that for the duration of the public health emergency. And so we're taking our cue from the federal government on their movement on these flexibilities, but that is certainly something that there's interest in our state, that if we're given those flexibilities federally to expand beyond those platforms. I think that Zoom and the providers who are utilizing Zoom and Teams and other products such as that have really found a way to demonstrate their ability to hold high HIPAA and the standards and efficacy of care. And so we've just continued to work with them, as well as our partners that we mentioned earlier, the licensing boards and those sister agencies.
Excellent. And actually, you mentioned platforms. And so we got a really interesting question in the registration. So people probably want to know, is Nevada Medicaid encouraging or requiring or asking providers in Nevada Medicaid to use a specific platform? And is there any movement around requiring some ubiquity around the platforms that they're using?
We do not comment on that, but as I mentioned earlier, our partnership with Nevada Rural Hospital Partners, they received a specific grant. And so they were pushing a certain provider of equipment. And so certainly many of our rural and frontier providers were utilizing this level of equipment. We just provide parameters within the HIPAA compliance, but we do link them. And so we felt it was very important as bureaucrats not to weigh in on a specific. So we did weigh in on our large hospital. We had our large hospital systems, those associations. When people asked us specific questions about equipment, we referred them to them because they were the ones using it and the boots on the ground in the field.
Very good. Thank you. A question here about how Nevada is maybe sharing their information around modeling the cost of changes to the state health plan. So if you are modeling the cost of changes to the state health plan to help those maybe colleagues in other states or in CMS understand the implications, do you make those cost changes public, or do you share it with other states or CMS?
So we have Nevada participates in a Western States Compact. And so many of the states, this has been a discussion, particularly for providers that are on a prospective payment system, like our federally qualified health centers and rural health centers. And Nevada also has certified community behavioral health clinics as well, or CCBHCs, which is a federal demonstration. And so we have taken really the path, and some of the legislation I think will point to this, to not have pay disparities. And so what we've really looked at, because for Nevada, the cost, we have been reliant on these services for years. And that's why we moved so forward with the policy 5 years ago, the legislation and the policy, because we have that's the only way for us to reach our rural and frontiers and some part of our urban access. And so what we'll be doing is looking long-term at the study of the cost of the savings within our transportation, our capitated transportation provider, and what telehealth has done for that, as well as the long-term implications of cost for those providers that are cost-based reimbursed, of what that does for infrastructure. Because there's certainly what we found with our providers, there was an immediate cost increase to get equipment, to get up to speed, to really make that transition. But now they're starting, as we've been doing this almost a year now, they're starting to get over that hump of cost. And so that's where our study will lead. And certainly we will be publishing part of that information as our involvement in the Western States Compact. And then independently, we will be working with centers of excellence like the Gwynn Center within Nevada, as we've given them some of our data. So we'll start to put some of that out within the next 6 months to a year.
Great. One person is asking about how Nevada approached e-consults. Did you change your policy to increase the access, and how did that go?
So we always allowed for e-consults, and it was very, because it was needed. We have several programs throughout the state, and as I mentioned earlier, specifically in the realm of behavioral health and managing those behavioral health crises, where the treating clinician may not feel that is within their area of expertise. And so they will use telehealth for the e-consult and the reimbursement, and also for the patient assessment and review, so that we can have a plan of safe discharge. We also have programs within our university that allow for consults with doctors that are funded through various other mechanisms, such as grants. So when it's not a Medicaid recipient involved, or it's not specifically for a specific recipient, that there's a mechanism to get that information out. So what we really did is reminded people that that was available. Recently, in the last 2 months with our hospital surge, we really focused on the e-consult with the nursing home facilities. We were facing, many staff were contracting COVID themselves. And so as a way to keep safe, to having the higher level staff do the telehealth visit from outside the facility with inside the facility while the CNA is actually working. We also work with a company here in Nevada that is offering these services where they offer boots on the ground, where EMTs go into the home and the providers outside the home to offer telehealth services, and that's Ready Responders. And we've had several other models like that. We also work with other agencies within our schools. They provide telehealth within the schools so that the child can then be seen, and if their needs are beyond the school nurse. So these public-private partnerships that we've engaged in have been truly beneficial for us to get the medical resources that we wouldn't normally have access to in Nevada.
Thanks, Dwayne. So we're gonna have time for one more question for Dwayne's individual Q&A. A reminder to folks that we'll be bringing the panelists back for panel-wide Q&A. If your question didn't get answered during the individual Q&A, please feel free to resubmit your questions, or we will make sure that we get to them at the end of the presentations. One more question. This one's probably a little bit of a softball. Can you remind folks if Nevada Medicaid is 100% fee-for-service, 100% managed care, or a little bit of hybrid for both?
Nevada is a hybrid, and so our managed care populations are two urban areas. That is where 90% of the Medicaid population is. So that is Clark County, which is the greater Las Vegas Bay Area, and Washoe County, which is the greater Reno area. But with the one caveat is our age, blind, and disabled population, they are excluded from managed care. And then we also, in the past, although we have moved away from this, those that were seriously and persistently mentally ill could get an exemption from managed care. So within Nevada Medicaid, we certainly saw, we were one of the states hardest hit by the pandemic. And so we saw our rolls increase 17% by over 100,000 individuals, the vast majority of those going to managed care. But that breakdown of the over 700,000, 1 in 4 Nevadans that are on Medicaid now, about 200,000 are in fee-for-service, and the remaining 500,000 are in managed care.
Thanks so much, Dwayne. At this time, we're going to be turning it over to our next presenter. Our next presenter is Dr. Shannon Dowler from North Carolina Medicaid. Dr. Dowler joined the North Carolina Department of Health and Human Services in 2019 as the Chief Medical Officer for North Carolina Medicaid. During the pandemic, she has led a ton of efforts related to telehealth and health equity with a focus on increasing testing in historically marginalized populations. She spent the majority of her career in service to nonprofits, including local health departments, providing full spectrum care, as well as a longstanding role with STD clinics as Chief Medical Officer for a large FQHC in Western North Carolina, and most recently as Associate Chief Quality Officer and Chief of Community Medicine for Mission Health System. She is past president of the North Carolina Academy of Family Physicians and has served on national commissions with the AAFP and ACOG. An avid educator and advocate for sexual health, Dr. Dowler speaks at local, state, and national level on STD prevention, diagnosis, treatment to both professional and lay audiences. One very cool and interesting fact about Dr. Dowler is that she is known by her other title as Rap Dr. D. She's produced 2 educational rap videos for lay audiences. The second one, called STDs Never Get Old, achieved brief international attention. She received her medical degree from East Carolina University, Brody School of Medicine, and completed a family medicine residency and fellowship in Asheville. We're pleased to turn it over to Dr. Dowler for her turn.
All right, thanks so much. Yeah, it's true. I get excited about STDs, and that's something that really upsets my children who are 18 and 20 years old, but they've gotten used to it now. But I also get pretty excited about Medicaid. I joined North Carolina as the Chief Medical Officer for Medicaid about a year and a half ago. At that time, we were getting ready to transition to managed Medicaid. And so I was learning fee-for-service Medicaid at the same time as learning managed care Medicaid, which is a lot. And then that ended up getting delayed, and then a pandemic hit. And so I got to learn pandemic Medicaid as well. So last week, I talked a lot about our telehealth modalities that we turned on and the data and what we've learned from telehealth in North Carolina. And today I'm going to talk to you more about our provider outreach and what we did to reach out to the providers around the state through the pandemic and what we felt was most successful. Next slide. So I think all of us have felt this way, that we've been building a plane as we're flying it. This has been an incredible time across the country for innovation and rapid movement in places where often rapid movement is difficult. And I would say state government is one of those places. We in North Carolina had one telehealth policy before the pandemic. We had convened a group in December of last year to do a telehealth modernization, which we predicted would take 3 years to get enough legislative support, federal authority, dollars, et cetera, to be able to expand telehealth the way we wanted to. 3 years was our plan. And instead, we ended up doing it in 6 weeks plus some. So it was a very busy time for us. But I'm going to talk about our provider engagement. Next slide. Of course, some of this is hindsight 2020. That's actually me with the microscope in the STD clinic. But as I look back on it and think about what really worked, where were our successes, it fell into 5 buckets. One was around transparency. One was around bidirectional communication, giving back, asking for help, and then celebrating. And so I'm going to tell you some examples of ways that I felt like we were able to use those tools. Next slide. Transparency. So a lot of people will accuse Medicaid programs of being sort of a black box where it's hard to understand what's going on, and there are all sorts of secrets in there and it's difficult to get to. And so it was really important to me as we rolled out our plans that we weren't just transparent to each other, but we were transparent across the whole Department of Health and Human Services, and then also throughout to all of our providers. We needed them to know what was going on. And I would say that extended also to our beneficiaries. Next slide. So I'm a super visual person. So early on, I started keeping visuals to demonstrate what we were doing because that helped me keep track of it. And at one point, I had a PowerPoint slide that was like 100 slides of all the different modalities we were doing, and realized that that wasn't going to work anymore. So went to this sort of consolidated visual, but we showed this visual very transparently to the Secretary of Health and Human Services, to all of our partners across DHHS, and even showed it when we spoke with stakeholders so they would understand the things we were doing from the waiver side, from DME and pharmacy, from long-term care, and then of course in the telehealth clinical side. Next slide. So as I said, telehealth was a huge part of this, and our telehealth transformation, going from 1 to over 100 in the period of 6 weeks, was not for the faint of heart. And we started in week 1, actually before we had just gotten our first case in North Carolina, but the governor hadn't instituted our stay-at-home order yet, with starting a series of webinars, weekly webinars for Medicaid providers. And that was not something we really did in the past at Medicaid, at North Carolina Medicaid. We would have them around transformation, which is our managed Medicaid transition, but they tended to be somewhat sterile, very scripted, to make sure people didn't say the wrong things, and which I'm often accused of saying the wrong things, but that's part of the whole transparency thing. But I started standing up these weekly updates. And each weekly update would tell the providers what we just did the week before, just to remind them what we were doing in that week, and then what was coming in the next week. So they could start kind of getting ready, preparing, and then making sure they didn't miss something from the last week. One of the first things we turned on was portal communication and telephonic reimbursement, neither of which we had before. And then also allowing federally qualified health centers and rural health centers to be distant sites, also something we did not have in North Carolina. You remember, we had one telehealth policy, and it was a consultative only policy for behavioral health services. So our waves went over about a 6-week period. Every time we thought we were done, we would have a stakeholder call and yell at us because we hadn't done something, that we forgot some kind of provider type or some sort of something. And so we kept expanding and expanding and expanding. Next slide. We were also really transparent early on, and I'm actually kind of glad to say I was wrong about some of it, about what we were going to keep on. So I had a lot of concerns that we were going to let this genie out of the bottle, and then when we tried to shove the genie back in the bottle, we would have way too much noise, and it would distract us from our other work. So from the beginning, we sort of flagged to people, hey, we're in a public health emergency. These are temporary provisions. This is not permanent. We'll let you know, but we're kind of thinking these things aren't permanent. So we would let them know as we were doing new things that we thought this was probably something we weren't going to continue. It was maybe something wouldn't continue, or it was for sure something we weren't going to continue. And some of those we were right on, and some of them we changed our minds. I was able to be convinced. Next slide. So overall, we had, I think the number now is 377 flexibilities across multiple functional areas. And we stood up a process I called the circuit breaker. My thinking was it took our team, 2 months of 80-hour work weeks. Really, I mean, no one's sleeping for 2 months to get this done. And next time we had a pandemic, I wanted to be able to flip a switch and we would just be able to turn on everything at once instead of this painful one-by-one process we went through. But what that also did was allowed us to convene a bottom-up process where we asked our SMEs, our subject matter experts, which of the provisions that we had made they thought were good and should stick and improved our Medicaid program, whether from the beneficiary or the provider perspective, and which ones should go away. They weren't great, they weren't safe, they were too expensive. And so they brought those through our leadership structure up to our executive team. And I will tell you that we kept, I believe, every one of the recommendations from our subject matter experts, except for 2 or 3, where we had some debate around. as far as what we were going to keep on after the pandemic. But starting in June, we started communicating that what we were working on, and we had a phased rollout of what was going to become permanent policy after the pandemic. And we're in our last round of that now. We're still working through the specialized therapies, physical therapy, occupational therapy, speech therapy, audiology, optometry. Those are, I will admit, we're leaving a little bit longer. Next slide. So bidirectional communication is something that felt really important to me as I joined Medicaid as a leader. It's one of the things that I had been frustrated with as a provider of healthcare. I'd been a physician in Western North Carolina for over 15 years. And sometimes you have really smart ideas and you can't tell anybody, or everyone's like, it's so obvious. Why don't they do this? But you didn't know how to get in and how to tell the right person. So bidirectional communication was sort of my mantra from the beginning. I would say my first mistake was putting my personal cell phone number and email address on the slide for the first webinar. We had like 1,400 people there. I was not expecting that many to join us. So then I started getting all sorts of phone calls and emails that I couldn't answer. But really, we tried to make it transparent. And I'm going to share some of the ways we did that so that people could take our information and then feedback to us. Next slide. So I talked about our webinars that we did. Over the course of March through June, we did a total of 87 webinars across 37,000 participants, which is a lot. We had the weekly webinars in addition to all these other ones that we would spawn up based on certain populations, specialty populations. And that was really effective and it became reliable. And what you see is attendance started towards May, and then you get into June, attendance started going down. And that was as people started coming back to the offices. So as we noticed that our surges were going down in North Carolina, the stay-at-home order was lifted, we had fewer attendees. And then we started staggering and going to every 2 weeks, and then we went to every month. And now we're back to every 2 weeks because we're getting ready to do managed care again. Next slide. When we looked back and kind of measured which of our webinars were the most impactful, which ones the providers liked the most, I think our weekly update was really important. People knew to count on that. They would often send their practice manager or their quality manager or someone to join us. When there were big topics like testing guidance early on, those were really well attended. Then we had special topics for certain populations. We actually did quite a few with local health departments across the state. We have 100 counties in little North Carolina with 85 different health departments. And so we would have meetings with those groups as well as the Rural Health Center and other specialty groups. The long-term care space was an area that needed a lot of attention during this time. We also partnered with the Department of Public Health and to talk about more kind of specific pandemic things. Next slide. We also created email and web access that was very different than in the past. We had really open websites with ways to reach us. We had a hotline people could call. We had a COVID help email address. We had actually lots of different ones to make sure that people's questions were being answered, whether they were beneficiaries or providers. Next slide. One of the things that was really a challenge is the special bulletins. So early on, of course, at the beginning of a pandemic, I don't know, I thought we'd be back together in the summer. I don't know what I was thinking, but I didn't think our stay at home would last that long. And I thought surely we'd be back on campus together, and we're still not on campus together. But we create special bulletins every time we made a major change. And then those special bulletins would be on our website. So providers could come look them up. They could look at the coding changes and have really clear access. It was all fun and games until we started hitting the 150s of special bulletins. And that is a lot of special bulletins. So we continue to do these, but not with the frequency that we did them at the beginning. Next slide. We also found that partnering, part of this bidirectional communication was within our own partners in Health and Human Services. And so we partnered really closely with the mental health, the Division of Mental Health, and to make sure that we were reaching out to their providers, their beneficiaries. So we would do weekly updates with them, side by side with them. We also had updates with we have managed care for behavioral health in North Carolina. So with those LME MCOs, we had all sorts of weekly updates for everyone that you can imagine in partnership with some of our sister divisions. Next slide. I spoke earlier about the long-term care. This was an area that, of course, I'm sure in your states as well, it needed a lot of attention, a lot of rules in Medicaid around long-term care and face-to-face visits that had to be modified. And then, of course, there was the issue of what to do about staff and staff being infected and having capacity. They were really under a lot of pressure. And so we made sure that we had lots of regular updates and outreach to the long-term care space, lots of ways they could reach us immediately if they were having financial hardship or needed other support. Next slide. Giving back. So it was important for us as part of this bidirectional communication that we heard the feedback of things that they needed and gave back. And so I'm going to share some examples of how we did that. Next slide. One of the ways was being really transparent on money. Of course, this was an incredibly stressful time for practices who suddenly went from having high volumes of visits to almost no visits at a time when we didn't have telehealth. So we had operationalized it, made it available, but they'd never done it before. And so they were learning how to build that plane while they were flying it, just like we were. And so financial issues and stressors were really important. So we had regular updates where we would let the providers know the kind of things we did to financially support them. We have a per member per month for medical homes. We doubled it early on in the pandemic, and we've actually kept it doubled still until the end of the public health emergency. We had certain incentive payments that normally require a face-to-face visit, and we made them available through telehealth because we wanted to keep engaged with our beneficiaries. There are a lot of ways we supported our safety nets. For example, changing their reimbursement at a higher percentage based on what they were seeing as decreased volumes. That's true for our dental clinics and local health departments, our federally qualified health centers. Instead of paying them $1 on the dollar, we might pay them $1.47 on the dollar just to help make sure that they had the financial infrastructure they needed to remain available to our beneficiaries. Next slide. Another thing we heard loud and clear was that because we hadn't done telehealth in the past, there were a lot of practices, particularly our rural health centers and FQHCs, who really needed support. And so we did a partnership with CCNC and AHEC, which are organizations that we contract with in North Carolina Medicaid, to create a provider outreach map. They actually looked at the demographics of the state and where we had the sickest population, old and sick with chronic illness, and then they reference that with who was billing for telehealth services for our Medicaid beneficiaries. And they found hotspots, areas where the population was really sick, but practices weren't doing telehealth. And they actually did practice support outreach to those practices to see what they could do to help them build a telehealth infrastructure. Next slide. Another piece of feedback we got early on was, it's great that you're saying I can do telehealth, but my patients don't have anything to do with it. And it's true. North Carolina had done very little in the way of telehealth, particularly in our Medicaid space. So we actually created a patient-facing educational video. It was not a rap video, but it was still pretty good. This was early in the pandemic, and so you couldn't go around video recording people. So I had physicians and nurse practitioners and therapists all around the state send me little clips of their own video. And so we also, of course, recruited all my family members to be in it. And it made it this patient-facing telehealth video about why telehealth is a good idea, why it's safe, and why it'll help keep you safe and well during the pandemic. Next slide. One of the other things we heard loud and clear was that caring for uninsured was a real challenge. Even though there was the HRSA portal, a lot of people had a lot of difficulty navigating it. And so we took in Medicaid, we took on the COVID testing cost for the uninsured and created that reimbursement methodology using our existing Medicaid system. And we did it in a way that was incredibly user-friendly and also beneficiary-friendly. And so that was a way that we were able to help back and provide support for the provider field. Next slide. So asking for help. This was also a really important part of our success. We did not do this alone. This took stakeholders from all over the state. And I'll tell you, anytime we got ready to release a new telehealth modality, before we did that, if it was around well child, you can believe we asked the family doctors and the pediatricians what they thought, review it, look at it, read it, punch holes in it. We want to make sure we get this right the first time. So we used our stakeholders to make sure that we were doing this right. And that meant, I mean, every week we were turning loose a whole nother slew of codes. It meant a lot of late evening meetings, a lot of urgent meetings, but everyone was really willing to engage and help. Next slide. One of the ways that we saw that we needed help was on vaccinations. We were seeing our children's vaccination rates go way down, really significantly down. And particularly in North Carolina, if you look at vaccinations, our Latinx population does a really beautiful job. But we were seeing theirs were getting down. They were doing as badly as our white population was. So we initiated something called Keeping Kids Well initiative through CCNC and AHEC, and we provided practice supports and worked together to get our immunizations back up, which worked really well. Next slide. We also had our practice supports that were in the practices helping them out do surveys every week. They would tell us, they'd feedback to us what it is the providers are worried about, what do they need help with, and that would give us some insight on what we needed to do next. Next slide. We asked all sorts of opinion questions as well on the general gestalt of things, not necessarily the literal things, so that could guide where our focus was as well. Next slide. The CCNC partner stood up a COVID hotline for us with very short notice because we were getting more phone calls than we could handle. And so they took thousands of calls for us on a daily basis and have continued to do that. We needed help and they were there to help us. Next slide. We also tracked unmet resource needs of our beneficiaries through this phone line to try to help with support. Next slide. And the final thing I'll say is celebrating was really important. This was an incredible amount of work, and particularly for people, a lot of my team had been in state government for a very long time, and they were used to things taking a long time. They were used to a modernization plan taking 3 years. That felt okay. And this was suddenly, we were modernizing day to day. So there was a lot of celebrating that needed to happen to make sure that everyone understood how important their work was and how it was impacting beneficiaries. Next slide. So we had a monthly cadence of creating major accomplishments that we shared with the secretary and with everybody. We made it public facing so we could really brag on the team and show the amazing work that had happened over the course of the pandemic. So this is just an example of one of our month's accomplishment slides. And that is it for my slides. I'm happy to take some questions.
Thanks so much, Dr. Dowler, and thanks so much for joining us for week number 2. We really appreciate you coming back. So we're going to now open the floor for questions that are directed specifically at Dr. Dowler and North Carolina Medicaid. We'll just start with some that we've received through the Q&A function. In relations to the priorities for the flexibilities, the subject matter experts that you talked about, were they Medicaid staff in the state? Were they practitioners? Were they state or public health budget officers? Who were they?
Great question. It was twofold. So we had our subject matter experts at Medicaid, and they are generally clinical, but if it was a financial provision we made, then it would be the financial team. So it was whoever the decision sort of rolled down to, we had them roll up their recommendations to us. But I also stood up a statewide telehealth consortium of people from around the state to weigh in on what was good and bad around telehealth, what we needed to do in the long term. So we also got external feedback.
Great. And in terms of that process and maybe a little bit more about the governance structure for how these decisions were made, were there public meetings involved?
No. I think we were moving so quickly. Now, my webinars were public. They were made available, and we would get hundreds and hundreds of comments and questions and answers in those webinars. But as far as broadly to the public, I would say no.
And I'm going to throw you a question also that we received through the registration page too about dental providers. Did North Carolina Medicaid do anything around dental providers? I know North Carolina Medicaid does have a dental benefit, I believe. So could you speak a little bit to that?
Yeah, we did a lot of dental. We had quite a few codes we turned on around dental. It was actually more than I imagined there could be using telehealth. So we all learned a lot about the ways that dental could help. A lot of it was allowing emergency care, particularly so that a child with a broken tooth, the parent could take a picture and send it in that asynchronous way. And then we also used audio visual for real-time assessment. In a lot of ways, we looked at it as triaging, allowing someone to say whether the beneficiary could stay home or take a risk of going out in public. But we did have quite a few dental codes. We actually had them before the pandemic and no one used them. And so it was another example of shining a light on something. And then we expanded it as well.
One follow-up question out of curiosity, the ability for the dental provider or dentist to take or the parent to send a picture, that platform, what is that platform called, and how did that process work for just getting that up and running?
It just varied by the practice. And so a lot of these were in our tertiary care centers that had dental schools, or in where there were dental residencies, or even our FQHCs that had dental clinics. You know, they would use their existing platforms.
Very good. Do you have any waivers in the state of North Carolina for out-of-state licensed providers to deliver telehealth care in North Carolina at the present time?
We did have some waiver around allowing out-of-state providers if it was needed, and that need really hasn't arisen. Like that, I believe it's been a while since I've heard a conversation about this, but I don't believe this was something that came in as an urgent need based on the pandemic.
Okay. We have a question related to how you're handling telephonic services, specifically around certified recovery specialists. Where is North Carolina Medicaid standing on that particular issue?
So I can't give you very specifics on the behavioral health space because we're in a managed behavioral health. And so I spend less time in that space than my colleagues in DMH do. I will tell you that we have a lot of telephonic care that we're reimbursing for in the behavioral health space. Behavioral health used our telehealth modalities, both telephonic and telehealth real-time audio visual, higher than our standard, and that we have gotten really positive feedback. So we're keeping on a lot of those telephonic provisions moving forward.
Very good. And I'll just follow up with one more question. We're going to have time for one more. In your opinion, from your perspective and experience during the public health emergency, how do you address the few but maybe vocal providers who are struggling with technology ramp up?
It's great question. We didn't have a lot of noise from that. Early on, we did. The noise was more of, I just want to use the phone. I don't want to do full telehealth. And so we pushed really hard on that. And one of the ways we were able to help them come along with telehealth was we made our reimbursement slightly lower for telephonic compared to telehealth. So we paid telehealth at parity for face-to-face visits, and we'll continue to do that. And we're doing telephonic currently in the pandemic at 80% of parity. But we also provided a ton of practice supports. So we tried to reach out to those practices and help them get aligned. Our medical society for the state provided a free platform. The Office of Rural Health also worked to provide a free platform. So we tried really hard to connect people with resources. But as a rule, I got very little negative feedback on that.
Well, that's great. That's great news. Thanks again, Dr. Dollar, for this presentation. At this time, we're going to transition over to Ohio Medicaid, and our presenter from Ohio Medicaid is Nicole Small. Nicole serves as the Health Systems Administrator with Ohio Medicaid. As a health plan policy administrator, Nicole Small develops and implements statewide telehealth policy covering approximately 3 million Ohioans and a large network of active providers. She is responsible for various Ohio Medicaid policies related to reimbursement, alternative payment models, and coordination of benefits. Nicole participates in the standards maintenance and development for electronic data interchange transactions maintained by the Accredited Standards Committee X12 and serves as secretary for the technical work group responsible for addressing requests for interpretation. She holds a Master's of Business Administration from Ohio Christian University and has more than a decade of experience in the healthcare industry. At this time, I'm pleased to hand it on over to Nicole Small.
Hi, good afternoon. Thank you for having me. So I'm Nicole Small, as Samuel said. I'm with our Bureau of Health Plan Policy at the Department of Medicaid. So I'm just going to talk to you about what we're doing in Ohio as far as telehealth. Next slide, please. So just a history of telehealth policy for Ohio Medicaid. We've had a policy in place since November of 2014. So that was a very limited model to start with. That was kind of like us dipping our toes into the water of telehealth. So it was a hub and spoke model. It kind of followed what Medicare was doing. We had a pretty narrow list of practitioners and services that could be provided through telehealth. It was really limited to psychiatric services and really was kind of intended to reach, the rural areas of the state where, they might not be connected to a lot of specialists. Like at Ohio State, we have the Cleveland Clinic and big providers like that, where our rural areas, might not be able to access certain specialists. So that was kind of the intent of the first iteration of our telehealth policy. So in July of 2019, we had expanded our telehealth policy. And so we added a lot more practitioners and services. We allowed, the patient to be at their home. That was a prohibition before. We, required the patient to present at, an eligible originating site. So the patient still had to go somewhere. Whereas with our July policy, we allowed the patients to be in their home. So right before kind of the pandemic, we, kind of expanded our telehealth policy. And then in March, we implemented some emergency rules. So in Ohio, we implemented emergency rules through executive order. So these are only effective for 120 days. So we followed up with kind of a more permanent rule that goes through our regular rule filing process. Next slide. So just, kind of our vision and goals for telehealth in, the context of COVID, it's really a balancing act as far as maintaining quality of care, enhancing access. We, of course, want to see better outcomes and flexibility for providers and patients. So that was kind of what we had in mind when we kind of developed this policy. Next slide. And so here's the emergency provisions that we implemented through emergency rule. So we had 3 emergency rules that we implemented through executive orders signed by our governor. So the first rule went into effect in March, so March 20th, but we, made that effective back to like March 9th, I believe. So providers could bill, this expanded telehealth policy, for dates of service starting March 9th. That was when in Ohio, the state of emergency was declared. So kind of lined up with that. And so it really, expanded the services and practitioners for telehealth. So we had to file another one in June because, the other one was expiring in July. We were thinking, like everyone else, maybe we'll be back on campus and, everything's gonna be fine by the summer. That wasn't the case. So we filed another emergency rule, actually 2 more, to make sure that, these provisions can continue. So that's why you see the 3 rules there. And then the last line here is the most recent rule that we adopted effective November 15th. So this is what we call a permanent rule. It's not permanent in the sense of, it goes on forever and ever. It's just permanent in the sense that it goes through our regular rule filing process where we have public hearings and things like that. We were still on kind of a tight time frame because we knew that, the most recent telehealth policy was expiring on the 14th of November. So we wanted to make sure, that we had something in place, so there was no, gap in services and things like that, that we could continue everything seamlessly for providers, after all the emergency rules had expired. So that's been in place since November 15th. And so we plan to revisit after the public health emergency just to, see what we're going to keep, see what's working, see what's not working, and just kind of revise our policy from there. Next slide. So just to include a definition of telehealth for Ohio Medicaid here, because every state kind of defines it a little bit differently. So we really defined it as the direct delivery of healthcare services to a patient related to diagnosis, treatment, and management of a condition. So it's an interaction with the patient. It can be synchronous, it can be asynchronous. Our previous policies required it to be synchronous, so real time with the patient. It had to be audio and video. But with our emergency provisions for telehealth, we allowed different activities that weren't, real time necessarily, or with both audio and video. So we allowed telephone calls, kind of similarly to what Medicare did, but we allowed a lot more services than Medicare did to be provided through telephone means only. We do have large rural populations in the state of Ohio. So we did also include some remote patient monitoring, and then just kind of communicating with patients through secure electronic portals, and to reimburse for those kind of activities. So it was kind of a broader definition of telehealth than we had previously. Next slide. So really just some highlights of our response with COVID-19. We expanded pretty widely the number of services and the eligible practitioners that can provide telehealth services. We eased the technology restrictions as far as the HIPAA regulations. We just kind of deferred to the Office for Civil Rights, their notification about the flexibilities under HIPAA. So we kind of just went with that as far as the guiding light as far as what technology should be used. We issued a lot of provider resources, telehealth billing guidelines, and some other, items that were helpful for providers as they were, working through this transition. It was really difficult for providers, like, many other states, telehealth wasn't super widely used, but, it kind of, the pandemic kind of, forced everyone to kind of pivot their practice. So we, issued a lot. We thought that was important to issue a lot of different resources for providers. And we've done that in the past with our policies. So with our telehealth policies, we found it helpful for providers to have kind of a billing guide to go with the policy. So we've had that, and I provide a link to that in later slides. But we also added pharmacists. So that was kind of not specific to telehealth, but just in general, we added pharmacists as eligible providers as of January 17th. So just last week that went into effect. And so since they're now recognized providers, they're eligible to do telehealth services as well. So that's really, they're doing like the medication management and things like that. And then just adding, hospice and home health services and nursing facility care, just making sure that, a lot of the different program areas that we have, long-term services and supports and non-institutional services can all, that all areas were addressed. So really it was a big collaborative effort within the department to make sure that, all the different populations and program areas, had some ability to do telehealth and for the department to reimburse for telehealth services. Next slide. So here's just a list of, some of the providers. These are the providers that we added in response to COVID. So this is not the exhaustive list of providers. It's just kind of what we added in response to COVID. So we added, a lot of the skilled therapies, occupational therapy, physical therapy. We found that this was really important for the schools. So in our Medicaid school program, a lot of the providers there told us that, this was really helpful in continuing a lot of the services that children were receiving in their individualized education programs, that they were able to continue, any kind of progress they were making in therapies through telehealth. So that was really, I think the biggest impact was with the schools. They really, had been kind of, they had been, vocal about it before. And so we were able to add it with the emergency rules. So we also added dietitians. We have a lot of behavioral health practitioners. And so this even went down to, the trainees that might not have a full license yet, but they're supervised. So we did allow these lower level practitioners to provide telehealth services. And then we did add dentists. We do have a teledentistry bill from our dental board in Ohio to do limited services through telehealth. So we added that. Optometrists, they can do a limited eye exam through telehealth. And home health and hospice agencies. Next slide. So similarly, we expanded the services that are able to be provided through telehealth. And again, this is not an exhaustive list, but just to give you an idea of what we added in response to COVID directly. So just kind of the asynchronous activities of, evaluating recorded video or images, virtual check-ins, remote patient monitoring, the, therapy services, even the hospice services and things like that. So we really, expanded it quite a bit. If you look at our at the policy itself, and then we have an appendix of procedure codes that are covered. If you look at it over time, it really expands, from 2014 to, pre-COVID and post-COVID. So it's really interesting to see how far it's been expanded, and it's really been helpful to providers, it seems. So next slide. So with the expansion of telehealth in Ohio, we really got a lot of feedback from stakeholders, like positive feedback. We heard, some practices were experiencing fewer missed appointments. So they had, a reduction in that. More people were seeking care. And so really the number of claims that we were getting really exploded since the beginning of the pandemic. And I know this, the data here shows April 2020, so it's a little bit outdated, but it kind of gives you an idea of how much it exploded from, March of 2020, we saw 1,000 claims per month. And then the next month it really, exploded. So it's really been helpful to providers, and we've heard a lot of positive feedback, even from the individuals that we cover, that it's been a real blessing and things like that. And so people, really want us to keep these things. And so providers have overall been very positive in what we've done with telehealth. Next slide. So here's just the some telehealth resources here. So we have our administrative code rule, the numbers 5160-1-18. If you care to read these boring rules, if you have insomnia or anything like that, they're good to go through. So that is a link to our telehealth rule. And then you can also find the appendix with all the covered procedure codes and whatnot in there. And so that's like our formal rule filing. And then we have the second bullet here is our COVID emergency telehealth resources. So we have a special site on our website really, devoted to COVID resources. And so here's where we posted our comprehensive billing guidelines for providers. And so that, we've continued to update if there's any changes with our policy and things like that. But that's been really helpful to providers as well. So if you want, you can, here's some resources you can look at if you'd like. So I'm just sharing that. Next slide. And just my contact information, if you have any questions or comments or anything like that, this is how you can reach me. And if there's any questions, I can take them.
Thanks so much, Nicole. At this time, we would like to invite the attendees to put additional questions into the Q&A function for Nicole and Ohio Medicaid. We have received some questions, so we'll just start with those. The first question is in relation to the definition that you use for telehealth in Ohio Medicaid. It seems this person is commenting that it seems to focus on the interaction with patients, but could you comment on your experience with e-consultations and how that fits?
So the e-consult codes, we did add a few of those to our appendix of covered codes. So we do have some of those e-consult codes that I think Medicare added as well. But we do allow, other providers aren't just restricted to using those procedure codes. So they can use others if, it's clinically appropriate and they're able to deliver the service, through telehealth and those means. So we did add those specific codes for e-consults, but we typically don't pay for consults between practitioners. So we wouldn't pay for one specialist talking to another specialist, without the patient involved typically.
Okay, and is Ohio treating group care delivery differently than individual care for telehealth? An example that this person provided is group prenatal care and group well child visits.
So right now, I don't think we have like a group prenatal service, but we do have I know the schools in our Medicaid school program, they asked for some group therapy services. So like our behavioral health services, there are some covered group psychotherapy and things like that. And I think we do have a, like not physical therapy, one of the therapies possibly, I think we have a covered group procedure code for that.
Okay. Is Ohio Medicaid requiring an initial in-person visit with an established provider in order to bill for telehealth?
So in Ohio, we're not requiring an in-person visit before someone seeks care through telehealth, but we do, if this telehealth provider is seeing patients over a period of 12 months or more, we do require, that patient to actually seek in-person care, at least one in-person visit per year. So if the telehealth practitioner is seeing this individual every month for 12 months, then the expectation is that that patient would come into an office. It doesn't have to be the telehealth practitioner's office, but just that the individual is seeking some sort of in-person care. So that was really important to make sure that patients aren't just receiving care through telehealth. And like our medical director always says, there's a lot you can't see in telehealth. You can't see how someone's presenting and things like that. So having that in-person visit is really important, and having continuity of care and making sure they're not just getting their services just from one source.
Great. One question about the process that Ohio Medicaid is going to go through for determining whether some of these rules will become permanent. Can you talk a little bit about whether some of these changes will be permanent in Ohio Medicaid and how you got to that decision?
I think with the overwhelming feedback we receive from providers, I think a lot of it will keep, but we do plan to see what's not working or what we're not really sure is appropriate for telehealth. So that'll be something that we consider with our clinical team, our policy team, and so it's really a group effort to determine what really will stay and what might not continue on. But I know our medical director has expressed interest in the audio. Telephone calls has been beneficial in Ohio because a lot of rural areas don't have sufficient broadband access. So in a lot of elderly folks, I think they're more comfortable typically on the telephone, but just allowing that modality we felt would be important to keep, just to make sure that people in rural areas can still continue to be connected with their practitioners.
Very good. Thank you. At this time, we're going to invite all of our panelists to join back with their cameras, and we're going to transition to a panel-wide Q&A. So this would be the time to ask any questions that you would like to know from all of our panelists. You can still ask a question that's specifically targeted at one of our speakers. If you do have a very specific question, we just ask that you drop it in the Q&A function and indicate who that question is for, so that we can make sure it gets to the right presenter. This question is about covering telehealth services related to healthcare transitions for youth. Obviously, that would be, perhaps in some states, it would be EPSDT transitioning into aging out at 21. Can you talk about any supporting these individuals in their transitions from pediatric to adult care during the public health emergency?
So certainly, Dwayne, I can go first. We have, of course, more stringent provider qualifications and qualities around those services to youth. And so, as I mentioned, we allowed for some services via telehealth for those youth, such as the rehabilitative mental health that we didn't for adults. And then, of course, that transition, we looked at that in stages. I think as we move forward, part of this, because of those allowances that we allowed for those youth services, what our data is really going to look at is the efficacy and effectiveness for that and what that had in the interventions. What we've been told anecdotally by our schools is that they are just absolutely overwhelmed with being able to provide the proper resources and supports. In Nevada was the third state in the nation to expand its school-based services policy outside of the individualized education plan. So nearly all state plan services are available to be performed by schools. And we did a heavy lift to transition those schools so that we can meet those burden of care for our youth within the state to telehealth and providing them resources, as I had mentioned earlier, with the companies, the private partnerships.
I can mention for Ohio, we do have, for kids that are transitioning out of foster care, we have a special eligibility group for them. I think they can be covered up until 26. So we do have that. I don't know of anything specific related to telehealth that we have for transitioning, but we do have like our managed care plans. They work a lot with the care management and transitions, and we work closely with our children's services agencies and different providers that work with children that are transitioning out of the system.
Yeah, no, I would say I'm not aware of there being anything specific but also any differences or limitations between the two. So there's nothing that comes to mind specifically.
Great. Thanks, folks. We have one question here about performance metrics. This person is interested in how your Medicaid agency has addressed potential provider concerns around the impact of shifting and transitioning to telehealth on the performance metrics for visits and encounters.
We still expect them to be amazing. So no changes there. No, this has definitely come up as we look at our quality metrics and a lot of things that have to be in person to do them, like pap smears. And, there are things that you can't do through the phone. And so we're definitely taking that into account as we're looking at this year. And particularly as we get ready to transition into managed care, we feel like baselines are going to be really skewed. Even getting diabetics to come in for A1Cs might be more difficult for people this past year. So we're definitely trying to have some grace in that area and look at it in the perspective that we've been in a pandemic together.
Same for Nevada. We are, because our policy covers both fee for service and managed care, so managed care has to abide by the policy that is set by both. We did have some relaxation with measures. Obviously, vaccinations were down as we had a very, prolonged stay-at-home order that went into different phases of pauses. And so obviously, we've also seen some measures there. Our fairly qualified health centers work with HRSA. We specifically worked with them to really transition them to telephonic because so many of their workforce were supporting those with COVID. And so they really couldn't see even the traditional people that they see. And so we've looked at adjusting those measures going forward, but we've also looked at ways to collect data measures with the Western States Compact to look at the quality and efficacy of those through telehealth with those services that can be delivered through telehealth.
And I would say the same for Ohio. So I know the performance metrics in our episode-based payments program, and we have a comprehensive primary care program that are heavily based on performance and things like that. So we've relaxed those requirements. Just it's been a real challenge, especially with the vaccinations for kids and well child visits and things like that. So everything's kind of jumbled right now. So we have relaxed some of those requirements and measures for the payment that's tied to some of those programs.
Here's a really interesting question. What have been the biggest challenges to keeping providers engaged and educated during the public health emergency and using telehealth?
I would say I found our providers incredibly enthusiastic. If anything, they were over attentive. So I heard about a lot of their frustrations whenever they had them, but we also tried to solve for them. I mean, I feel like I think they appreciated. I definitely got a sense that they appreciated how consistently we were working on it and how hard we were trying to meet their needs. And so I didn't feel a lot of frustration, honestly.
I'll say this, the former chair of our marriage and family therapist board tweeted me last night saying that the one good thing to come out of this pandemic is that the providers who were hesitant or slow to utilize telehealth and really see it as a solution for our state, it pushed them off the fence. And I'd have to agree with that. And I think overall, the providers now is, the flexibilities that we granted, they'd like to see, and as wide and expansive as our policy is, I think we won't see a return the way, even after, as we're all vaccinated and return to our workplaces and congregating publicly, I don't think that Nevada will see a significant return to a lot of in-person services because this flexibility has shown that you can reach the level of efficacy and care, and you can treat more individuals, especially when there is a lack of providers to cover all of the area.
And yeah, the same for Ohio. I would say, you know, our providers were they were very active, and, you know, we've kind of been in contact with them over the years and been involved in telehealth work groups. So we're kind of in constant contact with a lot of stakeholder groups and things like that. So I would say, you know, the challenge is probably keeping up with all the emails and things and questions coming in. So yeah, a lot of late days and weekends and things like that. So just kind of trying to make sure that we're considering everyone's feedback that, you know, we're getting in and getting responses out. I think that was, you know, really huge for providers.
And I'll add that I think our biggest challenge was billing. And we have a somewhat archaic billing system. And so we made all these massive edits into the system at the same time as we were asking providers to use modifiers they'd never used before and all sorts of other things. And they were already stressed out because their volumes were low. So getting the billing through our system in a timely fashion and working out those kinks was probably the source of greatest frustration, not the actual provision of telehealth.
It's a great point, and actually an excellent segue, Dr. Dollar, to our last question. This is going to be the last question we have for our panel today. Billing is a big topic. Billing is frequently a popular topic on all of the webinars that we are going to be hosting. How is your state, this is a question for everyone, how has your state been navigating some of those challenges around billing, specifically with telehealth modifiers, and has underreporting of those modifiers been a concern for your state?
Well, so we have a COVID line. We have several email lines dedicated to billing problems or COVID questions or others. And so we move those to the front of the line. So we try to be really responsive to billing issues because we know that this is hitting people, you know, so where they can't pay their staff and some places, particularly earlier in the pandemic, more so than now. So we've just tried to be really proactive and responsive when we realize that we made a mistake, or we tell them this is what's not working and why. And we actually can track the rejected codes, and we've found that we haven't had an increase overall compared to before the pandemic than after the pandemic. So the overall rate of rejections is about the same, but we try to keep that education and top of mind for everybody as we went along.
I would say for us, I think we had just a major lift, you know, very, you know, 3 staff that were really working with our fiscal agent, which administers our MMIS system. We didn't have, because we had been putting this information out for several years, we didn't have a lot of billing challenges. It was really from providers who had never done this. And so providing them the technical support and getting them the resources that were already out there. One of the other strategies that we did is with the major stakeholder groups, the associations, you know, myself and my chief and higher levels of leadership, meeting with them from a top-down approach to really deal with their systemic issues also helped to cut down on some of this. So meeting with the Department of Education, meeting with the Hospital Association, meeting with the Primary Care Association, which is the FQHCs, all of these different associations and stakeholders so that they could push out this information to their members was very vital for us.
In Ohio, with our emergency rules, we tried to make everything as flexible as possible. So we were accepting the place of service code 02. We were accepting a lot of the different modifiers. Excuse me. We were accepting a lot of the different modifiers. And so we kind of made it, you know, flexible for providers as much as we could. So we know that the data that we're getting in, and we have a telehealth dashboard to kind of track all these things. We know that it's underreported because at the, you know, a certain period of time, providers were not required to report all these modifiers and things like that. So just trying to be flexible, and we have 5 managed care plans. So just coordinating and trying to make it as consistent as possible is our goal.
Excellent. Thanks everybody for joining us again today for the presentation. At this time, I want to turn it back over to May Kwong for our closing remarks.
Thank you, Samuel, and thank you again to all of our great speakers, Dwayne Young, Dr. Shannon Dowler, and Nicole Small. And thank you everyone for attending today. Just once again to reiterate, This webinar was recorded. We will have it up about 48 hours later. Look for it earlier next week on our CCHP website and our YouTube channel. The presentations will also be made available as well too. So you'll be able to download those great slides that our speakers had. Our next presentation will be for next Friday. Again, it will be at 11 a.m. Pacific time, and we'll be learning about patient and beneficiary engagement and education. We'll be hearing from Maine Medicaid, also as well as Oklahoma and Virginia. And you can sign up on the CCHP website. The registration is here on the slide. Again, the slide deck will be made available. So once again, thank you to our speakers for a great presentation today. We hope you'll stay in touch with CCHP. You will receive an evaluation. We hope you will fill that out. We need that information to get back to HRSA because they help fund this particular webinar series. Thank you again, and everybody stay safe. Have a great day.